Welcome, everybody. This is Avoiding the Addiction Affliction, and I'm Mike McGowan. We're brought to you by Westwards Consulting, Kenosha County Substance Use Disorder Coalition, and by a generous grant from the state of Wisconsin's Dose of Reality Real Talks, reminding you that opioids are powerful drugs and that one pill can kill. You know, advertising for GLP-1 weight loss drugs are everywhere. They're on social media, television, radio, print. They're full of the promises these drugs bring. Well, how do they work? What do they do? And in general, how do eating disorders affect an individual's propensity, perhaps, for substance use disorders? That's the jumping off point for our conversation today with Dr. Kim Dennis. Dr. Dennis is the co founder, CEO, and chief medical officer at SunCloud Health, a board certified psychiatrist who specializes in treating eating disorders, addiction, trauma, multi-occurring disorders. She believes in and maintains a holistic perspective in the practice of psychiatry, incorporating biological, psychosocial, and spiritual approaches in a nuanced, individualized treatment plans. Dr. Dennis is a renowned expert in her field, published in areas of food addiction, the use of medication with family-based therapy for young people with anorexia nervosa, co-occurring eating disorders and self-injury, and gender differences in the development of psychopathology. Getting exhausted here, Dr. Dennis, but this is
That's
important.
enough. That's
Well, I don't know.
enough.
You've been on tons of networks and publications, and you also have your own blog, Abundant Living by Dr. Kim. And of course, for those of you listening, you know that links to SunCloud Health are attached to the podcast. Well, there we go. Welcome, Dr. Kim. How are you?
I'm good. Thank you so much.
We might as well start with the basics. I got to tell you, we've been told I'm older, right? Weight loss miracle cures just don't exist, right? But these drugs are subtly or not so subtly advertised as just that. Okay, so what do they do?
Yeah. Before I get started, I also want to share the part that was not in my bio that's probably the most relevant and most important, which is I've been sober for
Yeah.
24 plus years and I'm in recovery from an eating disorder as well as food addiction. So that I like to share that because that has certainly shaped my professional career, my research and clinical career.
Sober
So
from alcohol?
alcohol, yeah, and sugar, honestly.
My mom,
So,
Dr. Dennis, I've talked about this before. My mom was a recovering alcoholic, and when she got into recovery, she was so addicted to sugar that she would put teaspoons of sugar in her Coca-Colas
oh
until she was
wow,
able to wean
yeah,
herself off of that. But
yeah,
so
yeah,
back
yeah.
to
It's
GLP-1s though.
back to GLP-1. So, what are they? How do they work? It stands for glucagon-like peptide 1. It's actually a naturally occurring peptide in our bodies. And it affects multiple different organ systems. And of most interest to me is its impact on the brain. There are GLP receptors in the reward center and in other centers of the brain that are related to the reward center that mediate effects such as craving, that mediate effects such as the wanting component of addiction. We oftentimes hear this term food noise, which is
Hmm.
kind of a vague term, and that for a lot of people diminishes or goes away altogether when they're on GLP medications. And that's mediated by the brain's reward center. And not all that dissimilar to cravings that we talk about in the addiction field all the time. So, a part of how GLPs work is their impact on our brains. Another part of how they work is their impact on the pancreas. Another part is how they work on the gut. It slows down gastric emptying, increases a sense of satiety and fullness, has pretty well established effects on blood glucose levels. Originally, these are not new medications, also. These medications have been around since early 2000, but none of the lay public knew about what a
No.
GLP was. Like, I was in my psychiatry residency program at that point. I didn't know what a GLP was. I knew there were certain diabetes medications that were new that were coming out, but it was nothing like what we've seen since these newer, more potent agents have come onto the scene in around 2020, 2019.
When you do your workshops and you say reward pathways in the brain, I can just see addiction therapists perk up, right?
Yeah.
And go, whoa, whoa, what are you talking about? Because that sounds a lot like opioids and the rest of the drugs that we talk about.
Yep. Exactly. That's
So
exactly
how does
right.
that work? How is it? And you talk about the GLPs are psychoactive.
Yep. These are psychoactive medications. I actually believe that psychiatrists are probably better equipped to prescribe them when people have co-occurring psychiatric issues and addiction issues. Because we see our patients quite frequently and we have in-depth knowledge of addiction or eating disorders that sometimes primary care doesn't have. But the psychoactivity happens, the I think of most relevance to people's behavior in the way of drug use or substance use or eating. The reward center sends out the nucleus accumbens is what we typically refer to as the reward center, and it sends out projections to our prefrontal cortex. And two areas of importance are the lateral prefrontal cortex, which mediates cue reactivity, what I pay attention to in the environment. If I'm a person with food addiction, I am constantly zoned in on where the food is,
Hmm.
and not broccoli, right? I don't could really care less where that is, but highly palatable, highly rewarding foods.
Well,
If I'm a person with substance addiction, I am cued into where the drugs are. I'm cued into where the paraphernalia is. I'm cued into where the alcohol is. That is a brain mediated behavior. That's not a choice. It's not a. Oftentimes we hear the word like bad. It's a bad habit, or I gotta kick the habit, which I think subtly implies that there's choice involved, or that you could just stop doing it, which isn't the case really with addiction. So the lateral prefrontal cortex, what am I cued into in my environment? That's impacted by the GLPs. That's dampened down for people with addiction when they're on a GLP agonist. And then there's the medial prefrontal cortex, which is really my capacity to inhibit my impulses for my greater good or for the long-term game, right? Ooh, I really want to do that right now, but I have a podcast with Mike, so I'm going to just delay that until we're done here and then I'm going to go do that thing. Right? People who are actively in the grips of addiction, regardless of what the substance is that the addiction is playing out with, have greatly diminished capacity to inhibit those impulses. And when a GLP is on board, they have essentially they get a brake job. Their brakes somehow work again. And this is not to say that these are miracle drugs that should be used for all people, because there are certainly some groups of people who the risks of being on a medication like this outweigh the potential benefits.
okay, there's a lot there. When you say the brakes work again, and then going back to your first comment about psychiatrists are probably better equipped, the brakes work probably, I would guess you're going to say better if you're seeing a therapist at the same time.
Yes. So that's part of why these are not miracle drugs. When we're talking about addiction, one of the things that co occurs very frequently with addiction is trauma. We know that social quality of life for people with addiction is usually very, very poor. GLPs don't give somebody the capacity to know how to have mature, meaningful relationships with other humans. After disengaging from that for the last 10, 20 years or ever, because they've grown up in situations where they never learned what it means to be in a mutually giving, mutually beneficial, interdependent relationship. So, all of those skills that we work with people on in recovery and in therapy, that doesn't come along with a GLP medication.
Do you have a sense? I don't know this, Do you know what percentage of the medication is being prescribed by psychiatrists and how much of it is being prescribed by primary care physicians?
Yeah, the overwhelming majority is by primary care, but I
Hmm.
believe I just read earlier this week up to 10, I think 10% now is being prescribed by psychiatrists. Another reason in psychiatry is co-prescribing it with atypical antipsychotics, which cause a lot in the way of metabolic side effects for people with bipolar disorder, schizophrenia, who tend to die 10 years earlier than their peers, in large amount because of medical comorbidities associated with weight gain, associated with medication they need to be stable.
I'm not throwing them under the bus, but what would the primary care physicians be missing if they're just prescribing the drugs? Because I would imagine that physically, biologically, the drugs would work in the way you've described, but what are they missing?
The area that I am most concerned that they are missing is eating disorders, honestly. And particularly within eating disorders, people with eating disorders that are not disclosing that they have an eating disorder and who are using these medications inappropriately, or people with atypical anorexia nervosa, which is anorexia nervosa in a larger body. So somebody might meet BMI criteria for obesity, but have classic anorexia. And that person can have a lot in the way of medical compromise and medical instability if they are put on a GLP medication without any sort of understanding that they have an eating disorder.
Even in your field, it's not universal that people treating eating disorders believe that that there's an addiction involved, right?
I
It's
I would go way further than that, Mike.
okay.
It's vehemently protested in the
Why?
eating disorder
But
world.
you think it is though, right?
I think, and we do research at SunCloud, and there's a lot of research in the literature that shows a large overlap between food addiction and eating disorders. But not everybody who has an eating disorder has addiction. And some people just have food addiction and they don't have a DSM diagnosable eating disorder. So
Yeah. It's
it's three groups really, people with both, people with just an eating disorder, and people with just a food addiction. And there's very little understanding of that across those three camps. And that does a lot of damage to patients who are trying to get care, individualized care for their own disease package.
and you do individualized care at SunCloud,
I
right?
believe very strongly in individualized and nuanced care.
How
You know, what
important
works
is
for one person is might actually damage another person.
like most addictions, there's secretive, dysfunctional family stuff that goes on all over the place. So how important is the family in the process?
I think family is so important in any sort of recovery process that we talk about, whether the person is living with their family or not, because so much of there's intergenerational traumas, so much of how we learn how to show up in relationships comes from what we learn in our primary environments. And families know, like parents much of the time really know their kids and really love their kids, even if there's a tremendous amount of dysfunction. And when that is there, there's a lot of hope for not only the patient entering recovery, but the whole family system entering recovery, and there being mutual support for not only the identified patient, but the whole family system to leave treatment on a different path, on a better path. That's more fulfilling for everybody involved.
When we talk about the GLPs, I'm now seeing commercials where it's available cheaper and in pill
Yes,
form. So
yes.
I know where this is going, right? Are we at the point where we'll get over the counter at some point?
I think we are far away from that, at least in a legal way. But where we are at, which is I would say unprecedented is people having access to these medications at the touch of a button on their iPhone or on their computer. And a lot of that is through telehealth
Mm.
platforms where you don't actually see a doctor and you can put whatever information you want to put in the little survey questions, including weight. So I've treated patients with anorexia who have gone onto telehealth platforms and had GLPs delivered right to their house. I'm concerned about this with kids, especially. And there's a new GLP called retatrutide. I think I'm getting that right. It's in phase 3 trials right now. It's a triple agonist with even greater weight loss. And this is not a legal medication, but there's a black market for this. People are obtaining this medication already through illegal means and compounding facilities that the government is trying to crack down on. So this is very different than circa 2000 GLP medications. And I think that always gives me a pause. These are undoubtedly powerful medications with potential to, I think, transform not only diabetes and metabolic medicine care, but potentially offer a lot of benefits for people with addiction and potentially other uses in psychiatry. But I'm also a big believer in the evidence base, and we're just beginning to get an evidence base with alcohol use disorder.
And
And
GLP-1s.
yep,
Yeah.
yep.
And you can see the day where we do it with opioids as well, I would imagine.
Yeah, I think the data is not out yet for opioids, but if these medications are, Nora Volkow at NIDA talks about these medications as potentially having anti-addiction, anti-compulsion effects. And if you are a person that believes addiction is a brain disease and the substance is not necessarily causal, but you need the brain disease and the substance both interacting to have the disease, the addiction at the central brain reward level can be arrested or mitigated, I won't say arrested, but impacted by a medication that theoretically works on that brain system that doesn't really care if what the substance is highly palatable foods or alcohol or
Hmm.
opioids or stimulants. We have nothing medication wise for stimulant use disorder. So there's a lot of hope, but we're still quite a ways from being able to say we have enough randomized double-blind trials to know that these are safe and to know that they're effective.
But I would imagine with most medications like that, where the clinical trials aren't involving children.
Correct. I mean, there are clinical trials involving children for GLP medications for diabetes and weight management. So those trials have been done and are ongoing. I don't know of any GLP trials in adolescents or children for non-diabetes or
Hmm.
non weight management related indications.
While there seems to be controversy, and you talk about it in your workshops around the food addiction area, there isn't much controversy when it comes to the middle of the grocery store. And you spend yeah, you spend time talking. You mentioned broccoli before. The ultra processed stuff. Man, oh man, that's gotta somebody in your field that's gotta just create havoc.
Yes, I think the hardest part about food addiction, one, ultra processed food addiction is the best name we have for it right now, but it's not a perfect name because somebody who has food addiction is going to have the same brain response to a home baked cake, which would technically be a processed food, not an ultra processed food. The ultra processed version would be like Dolly Madison's version in the middle of the grocery
Hmm.
store, right? So it's not a perfect term, but it makes it hard to treat food addiction because there isn't an agreed upon, it's not in the DSM,
No.
it's not in the ICD. It's hard to get funding for things that are not actual DSM diagnoses yet. We have proposals in. There's a group in the States working on a DSM proposal, and I know that I was part of a group that submitted a proposal to the ICD to have it included in the next version. But these foods are so pervasive. They're marketed to kids. Nobody's marketing cigarettes or alcohol to kids, right? But they're given to kids in schools, right? In hospitals. We used to have cigarette vending machines in hospitals. Do you remember that?
I do.
Yeah, they're not there anymore. But we still have vending machines full of foods that now are associated with things like type 2 diabetes, heart disease, cancers, depression. So I think there's a lot of money in big food and a lot of huge lobbying dollars that I think got in the way of the progress of this science. But I think the science is marching ahead anyways. And certainly there are people, patients out there suffering from this who are seeking solutions and who deserve solutions.
And then on top of that, you still have the two big ones for me with all addiction, but I think food fits right in there is both stigma and socioeconomics. The middle of the grocery store is just made for the lower socioeconomics. Every time I go past the cheeses in the fresh cheese counter, I'm like, I can't afford that.
Yes, I'm really glad you brought that up because I think, particularly with food, we have a two-tiered system in America. And certain people are able to purchase whole foods and fresh meats and fresh vegetables and fresh fruits, and other people simply cannot. So if we're saying to people, eat whole foods, or if in the eating disorder world, there's a dogma of all foods fit, because a lot of what we work on is rigid, like diet
Hmm.
mentality. But do all foods fit if you have food addiction? No. You still have to eat, but you don't have to eat the foods that you have addiction with, right? Nobody needs to eat Dolly Madison ho-hos every day, but you have to eat. I have to drink. I'm going to drink my water because I need to, but I'm not going to be drinking alcohol today. I think there's just so much pervasive built into our society, into our social functions, food, and specifically celebratory foods, right? Cakes. Think of a wedding. Champagne and wedding cake come to mind for a lot of people. But I've been to plenty of weddings where instead of wedding cake, there's something else, like a wedding fruit platter. And instead of a champagne toast, there's a sparkling grape juice toast. And the meaning is still there. So I think we're a ways off from having the food environment change and having the awareness that we need to have to adequately support people just generally from a perspective of health, but certainly for people with addiction involving certain food substances.
I've been doing this for a very long time, and I will occasionally get into this topic. You just brought it up. I think it's really difficult for people to discuss because if I'm addicted to fentanyl, I can stay away from fentanyl. I can tell my doctor, don't give me these painkillers, but I got to eat. I have to drink. And I think that makes it difficult to work with, which is where it moves out of the GP, the general practitioner, into the therapeutic realm.
Yes, and I think that's particularly true for people of lower socioeconomic means who may be addicted to food, but really can only afford to shop in the middle of the grocery store on foods that are harmful for them, right? So, how do we help people generally, given the pervasiveness of these foods in our culture and in our food supply chain, but especially how do we help people who are saying, hey, I think you, and who are coming to us saying, I think I'm addicted to, I cannot stop eating these things, but it's the cheapest thing that I
Yes.
have. I can go get three Happy Meals or Big Mac meals at McDonald's for the same price I would pay for one piece of fresh whatever from Whole
Salmon.
Foods. Exactly.
Yeah. I'll let you go with this. I'll be sensitive to your time. Where do you think we are then in 5 to 10 years with the GLPs, with food addiction, with the field that you work in?
Yeah, so I think 5 to 10 years from now, we're going to be at a point where these medications carry indications for certain addictions,
Give me
probably alcohol use disorder.
really.
Yeah. I also think and hope that there are going to be a lot more regulations and oversight over the prescribing of these medications, particularly via telehealth. There's a lot of interest in getting that sort of oversight tightened up. And I think that's really necessary given the power of these medications and just how quickly things can go very poorly for
Mhm.
people without oversight and competent, appropriate prescribing.
I lied. I want to ask a follow-up to that. How can they go wrong? Where do you see it going wrong?
There are people who come to treatment at SunCloud who have, like, for example, oh, I had a history of anorexia when I was a teenager. Now I'm in my 30s. My BMI was 35, so I went to the doctor, got a GLP medication, and I've only been eating 200, 300 calories since, and it's been months. And their heart rate is 45, and their blood pressure is 80 over 50. Their electrolytes are all out of whack. They've lost a lot of muscle mass, and they're right back into anorexia mentality with body image distortions. And that's an example of it going very wrong.
So, like most things, there's a real upside to these chemicals, and then there's the associated downside as well.
Yep,
Oh.
yep.
Dr. Dennis, this is, or Dr. Kim, I think everybody calls you. This has been fascinating. For those of you listening, please look at the link to SunCloud. There's so much stuff there that we just scratched the surface. Um,
Yeah.
I, I so appreciate your work. I appreciate you taking the time to be with us today. For those of you listening and watching on YouTube, we hope that you find peace, contentment, health wherever you are. Thanks for watching. Be safe, be well. And I've been adding this lately. Be educated.